Okay, so I do have questions about what happens if, for example, a health facility, a health clinic in my district, because I represent some rural areas, I have a question about that, but that's separate. I wanted to just clarify about the 14 existing. Are they going to lose their job, or is it that they keep their job as long as they continue to have supervision, which they don't have today?
For those individuals, if they were to remain in their current place, they either would keep their job and retain physician supervision, or if they wished to be independent, then they would need to either work for the medical group, form their own nursing corporation. They will not lose their jobs. They simply would have a choice of continue to practice supervised or choose to exercise discretionary independence, in which case they'd have to change their situation.
And I did want to clarify, we had a conversation with Ms. Burke in her office right after the amendments were taken on May 28th. We were probably in there around June 1st or something, May 30th. And we discussed that at that time, we knew of at least 14 off the top of our heads, just talking to a few of our members. We did do an informal poll, and about 20% of those hospitals that replied to our informal poll did employ. So for us, it is not a hard and fast number, 14. We had a conversation, and we said in our telephone conference call with some of our members, we knew of at least 14 that were employed. I don't believe that is the entire universe of folks working. But the Employment Development Department did not have good data on this, and we went to several places. We had our data person looking at several sites for appropriate information, and that was what we were able to come up with at that moment.
So the author, you've done a wonderful job. You've come around and talked to me twice, and sometimes the author does such a good job on their bills that they're ahead of people who are in our districts that are responding. And in this case, while we've talked, I had a late response today from one of my hospitals. So the concern that I didn't think about when we talked was what happens if you have a new health facility open up in a rural area that maybe has one physician there part-time or something like that. I understand that there's some amendments that are being proposed by the committee today, and I'm a little bit unclear about whether the rural health facilities are exempted from the corporate practice of medicine or whether they're not, and what the amendments that are.
Hospitals are. If I could, thank you, Senator Galgiani. The amendments that we've asked the author to take and they're really designed to increase access, which is what the author wants. I think we all want to. I mean, this is an outstanding profession and one that and the goal of this bill. But as the author said, that this has become a fight over CPM. Well, then, if it's a fight over CPM, why is CPM in the bill? It shouldn't have been in the bill to start with, because we're talking about midwifery and we're talking about providing greater access for midwives. And here, all of a sudden, this outside influence comes in that throws a curve at everyone. And that's the real challenge. And what the problem is, I see it, with the bill as written, without the amendments, and what the amendments would do as adding to there are many exemptions for the corporate practice of medicine, many exemptions. This would add an exemption for certified nurse midwives that they could practice in any nonprofit hospital and any nonprofit clinic in the state. That would allow them that opportunity, because to me the issue is, and there are many urban areas where we have a challenge. There are many urban areas where there is difficulty finding the good services that you're providing because it's difficult to get a physician, an OBGYN to supervise. And that's really the challenge. But if you're looking at a rural area, someplace in a small county someplace where you have no supervision, so you can't have a midwife today, a certified midwife, because there's no supervision provided. But now we've thrown another curve at them and kind of a catch-22. Now with the CPM in place, these nurse midwives, certified nurse midwives who now want to practice in those rural areas, they can't be employed by the hospital. But what are the odds of them in that area forming a corporation, gathering with many nurse midwives to come together, and having the resources to establish a practice in a county where there probably is one midwife in the county to start with? just as there may be no physicians. We talked about the number of areas that have this challenge. That's, to me, is what the issue is related to this. It would be fine without that, but now we're putting a burden now on those nurse midwives who we want to make sure have an opportunity at some point in time in those rural counties to be able to do it. So that's what the amendment says. We'll just add an exemption. It says nonprofit hospitals, nonprofit clinics, because the arguments that I've heard that have been raised against or in support of CPM by those who have supported CPM is talking about the for-profit corporations. I remember hearing one related to the private jet that was hired, or the jet that was hired to take a patient someplace. That was a for-profit hospital. We're not talking about for-profit hospitals here. Those for-profit hospitals, they should be subject to the corporate practice of medicine. It's those nonprofit ones that we're concerned with, and that's what the amendment is about, that the author has chosen not to take.
With all due respect, Mr. Chair, but I do want to say that portions of the amendment you actually asked for were already in the bill. So the clinics were already actually existing in the bill, and in your area, for example. Yes, they actually would still be allowed to hire a certified nurse midwife. The certified nurse midwife would just work under supervision of the hospital, which chances are their bylaws would require anyway. That's why in this particular bill, this wasn't the pill that in so many other situations that it is to swallow, because by design, most hospital bylaws require them to work under supervision. So that's why they would still be able absolutely to hire certified nurse midwives. We wouldn't take an amendment that would not allow a certified nurse midwife to work in a rural area. It's the entire purpose of the bill is to expand access to so many women who don't have access, especially in your district. We've talked about this. You have less than two, you're one of the people who has less than two OBGYNs per 10,000 women. We wouldn't have taken an amendment that would have made it impossible for them to have that access. That's the entire purpose of the bill. So yes, they would be able to work in rural communities, either independently outside of the hospital or as employed in the hospital, and they would definitely be able to continue to work in clinics, because that is actually one of the exemptions that we put in the corporate practice of medicine portion of our bill.
The exemption in the bill states currently that it's a clinic operated by a nonprofit corporation as an entity organized and operated exclusively for scientific and charitable purposes. So that's not a nonprofit clinic that would be it could be someplace in a rural community. And I think what we're looking at here today is not just what's occurring in Senator Galgiani's district or what's occurring in my district, but those districts that are in areas that are not being served today. Senator Berryhill. I'm sorry, Senator Galgiani, were you finished?
I just wanted clarification on, then the vote before us will be an amended bill.
We haven't gotten to that part yet, so okay. We'll clarify that when the time comes, if that's all right.
Okay, okay.
Yeah, Mr. Chairman, can I defer to the vice chair here, and then I do still have some questions.
Absolutely.
I want to listen to our
Senator
vice
Hernandez,
chair.
you'll be next after the deferrals over here.
First of all, my concern, being my first year in B&P and back in the legislature, is the expanded scopes. And what I've seen in a number of them is allowing what I consider to be less credentialed in terms of pharmacology to a number of the expanded scopes. So we have people able to prescribe what are very significant drugs, and we have a proliferation in our community of those opiates, out there. In fact, there was a huge article this weekend about the use of those by the 18 to 25-year-olds, which gravitates into the use of heroin. So when I'm looking at these bills and seeing that we are giving the opportunity to prescribe Schedule II drugs on up, it always troubles me. That's where I have some real issues. And I'm reading from our analysis that says, specifies that in a non-hospital setting, a Schedule II drug is only administered during labor and delivery and only after consultation with the physician. And I'm hearing the presentation say that's the problem and why we need to have this bill to allow midwifery to be able to practice without the oversight of a physician. So if you're going to be in a non-hospital setting, you're out there and you're able to prescribe a Schedule II drug, one of the most significant, and you have to have physician consultation. How does that fit in with your presentation that that's the problem? There are not physicians available that will provide that oversight, and therefore the malpractice issues that are involved. Help me understand that, because that's a big issue for me.
One of the principal tenets of nurse midwifery is collaboration. And as one of our witnesses said, OBGYNs collaborate with nurse midwives. Sometimes they get in the way. It was a lighthearted comment. But nurse midwives do not practice without ensuring that an OBGYN in some way, shape, or form is involved. And in this one sentence here that you're mentioning with regard to Schedule II controlled substances, that was a carefully negotiated item with the Medical Association on the very issue about which you're articulating concerns. So in a way, what this one item does is it reinforces the collaboration between two distinct practitioners to ensure that the best care possible is provided, and especially for something as serious as a Schedule II controlled narcotic, that having some degree of consultation is very important to ensuring an outcome. And it shows, I think, also the degree of willingness and just professional dependency on the interaction between both the OBGYNs and the nurse midwives.
Well, I appreciate that. I don't think it goes far enough, because we're saying consultation is different than supervision. And I'm thinking, how does one consult at the point in time that, baby's on its way? And I mean, we all know a lot of the drugs that are used for certainly pain, and then after some of the postpartum issues. I don't know, I'm just real uncomfortable with that, and yet I want to know. I've had a meeting in my district office with Ms. Snell. It was wonderful, and the stories are wonderful, so I'm kind of there, but I think that this issue of not being able to be in a hospital and, the situation with the CPM, and my major concern over the growth and the misuse of drugs and the prescribing of those it's a hill for me to climb at the moment. So I won't be able to support it today. I just hope that we continue to work on this issue regarding the CPN, because I think that maybe gets me closer.
May I respond to the prescribing piece?
Yes,
because I appreciate that.
And let me know, I'd like to know what your education on that front is as compared to an OBGYN or a doctor in particular.
I think that, I know, as far as the education is concerned, we have specific pharmacology courses that go through the pharmacokinetics, pharmacodynamics of drugs, whether they be an antibiotic versus a controlled substance. We have content that is specific to controlled substances. By state law, we have to have a minimum of a 3-unit, 45-hour course, which in some regards is comparable to those in medical school. I don't know all of the medical schools, so I can't speak to those. I can speak to the midwifery curriculum. We are the clinical component of our education requires us to have not only the knowledge, but also the experience under supervision of a nurse midwife and other physicians that are available to be able to demonstrate that we have both the knowledge as well as the understanding of the appropriate use. We further, when we do graduate and have the national certification, then we go through the rigors that the Board of Registered Nursing is put on as far as getting a license in California, certification in California for our furnishing. And then we have to also meet the requirements for the DEA. And the federal registration through the DEA is no different for us than it is for any physician. We agree with you. We want to make sure that there is not abuse of those drugs. And if you, since our enabling legislation that gave us the Schedule controlled substances, including Schedule IIs, there has not been, to our knowledge, nor the BRN, nor the DEA, Department of Justice, any nurse midwife that has been investigated or a complaint made based on their abilities. Nurse midwives are very careful. We don't utilize those drugs inappropriately.
Senator Berryhill.
Thank you, Mr. Chairman. I got a couple questions, and I guess my first one is to the Hospital Association, and your explanation about these new amendments and stuff. Are you familiar? And what's your first of all, what's your response to his comments?
To the chair's comments?
The chair's comments.
Well, we understand that the amendments that were proposed in the bill are something that may not be considered today, but if those amendments were, our CHA's position would not change.
Okay. Well, here's kind of my deal. I represent a tremendous rural district, and with the under the new Covered California laws, the author would make the argument that we're actually going to get more access out of this thing. I would think that your argument is that at the end of the day, we would have less access. Yeah, no?
Well, with the proposed amendments, it doesn't cover, it only provides for relief for a partial list of our hospital members. If corporate practice of medicine is a hurdle for one hospital, it's a hurdle for all hospitals.
Do you guys have a response to that?
It's
like, I'll be honest.
I mean, if the language weren't in there, we would not see the hurdle to getting these services to the folks that need it in the community, whether it's rural or inner city or communities of color, where we see trying to recruit those types of folks to come and provide services. The ACA created a large number of people in our system, and we want to make sure that we are able to provide services to those folks through an integrated model and getting everybody to provide services.
Yeah, Peter.
I want to be very careful because as the advocate for the certified nurse midwives, I don't want to be advocating for or against the corporate practice of medicine. But I think that in this unique case for certified nurse midwives, they have 40 years of history of practicing in hospitals. They're not employed by hospitals. They've had the ability to do so regardless of whether the hospital is subject to a corporate practice of medicine exemption or not. Given the history as well of during these 40 years of seeking work in hospitals and not being able to, being employed directly by hospitals because of the medical staff decisions, there's no reason to think that the language that's in the bill will have a suppressing effect on the future employment of nurse midwives.
All right. I guess, Connie, is there any way that we can get this bill to where you would be in favor of it or neutral of it in it?
The removing of the corporate practice of medicine. Which,
right. When no
to answer your question, Senator.
Sorry.
Okay, what say you?
The issue is that the Hospital Association is not addressing is the actual bylaws of the hospitals that they represent. It's not the corporate practice of medicine right now, is my understanding. It's that the hospital bylaws actually require supervision. So it's not just the corporate practice of medicine, it's actually each individual hospital has their own set of bylaws, which corporate practice of medicine or not supersedes right now. So if there is, in fact, if we took away supervision and the hospital maintained in their bylaws that certified nurse midwives must be supervised, then they must be supervised. So that doesn't change the effects on this bill. I understand, listen, and I understand, yeah, okay. I didn't want you to think I didn't understand.
If I may address the bylaws issue, Jackie Garman from the California Hospital Association. Yes, it's correct. Each individual hospital does have its own medical staff bylaws. If individual hospitals have elected to impose limitations requiring physician supervision, that can only be because that's what the law currently requires. If the law were changed as this bill proposes to eliminate the physician supervision requirement, Frankly, I don't know that any hospital has considered what they would have to do in that circumstance, but bylaws are amended all the time. And hospitals and medical staffs are required to review their bylaws to keep them in conformity with the law. And as a lawyer who has addressed the scope of medical staff bylaws many times in my past practice, I would be very concerned about maintaining a requirement in bylaws for physician supervision if the law no longer requires that because of the antitrust concerns involved. So I think saying what bylaws currently require, which is in compliance with current law, does not in any way address what would be the case if the law were changed to eliminate the supervision requirement. And I'm assuming that hospital medical staffs and their governing boards, who are ultimately responsible for approving those bylaws, would bring their bylaws into compliance with the state of existing law.
Yeah, this, just as a closing comment, this has been a very difficult bill because we're kind of caught in the middle of a political football here, and so it makes it very difficult for us. So I'll take it all into consideration. I still haven't made up my mind.
Thank you, sir.
Senator Fernandez.
Yeah, walk me through currently, putting aside this bill, what's the standard of care or standard of protocol with midwives and physicians at this time? And right now, what's the typical business model?
Well, I think the business models are as varied as any other kind of healthcare professional in a global. But in a sense, the way our current law is written, it says that we must practice under the supervision of a physician and surgeon. The next sentence says supervision does not mean direct presence. So what that means is anybody's interpretation. You can have a physician that is in the community that you're in. You can have a physician that is actually in the hospital where you are. You can technically have a physician that is at the other end of the state. Now, I don't know anybody that does that, so I don't want that to be
currently, the way it's written, is it difficult for a nurse midwife to practice or to find a physician to set up a standard, a set of protocols?
Yes.
So it's very difficult. What is the reason for that?
The main reason for that is the malpractice insurances.
And the liability that would be taken upon by the OBGYN or the physician, is that correct?
It is the malpractice company's contention that if the physician supervises the midwife, that they have additional liability, whereas with the removal of supervision, the midwife is responsible for their autonomous practices, and the physician is responsible for theirs, and therefore that supervision is no longer there, which opens up the ability of both being able to do the autonomous practices, which is what is recommended by national standards.
So currently, would you say the majority of OBGYNs have standards of protocol, or is it a small percentage of them that do?
Say again.
So would you say the majority of OBGYNs or physicians have standards of protocol with nurse midwives, or is it a smaller percentage of them that do?
I would say
in other words, it's difficult.
Yes. I would say those that are in hospital-based practices do because they're under medical staff bylaws. And whether that would change or not remains to be seen. It may be an evolutionary thing, but I will tell you that many nurse midwives have had the opportunity to talk with many hospitals about let me practice in your hospital, and because there's not a physician that would supervise, that they cannot gain those privileges and therefore not be able to open up access. And that is something that has been one of the reasons that we wanted to move to removal of physician supervision so that we can, in fact, work with those hospitals and other clinics, et cetera, to be able to offer those services and therefore have greater access. I'll give you one very quick example. There are midwives that have been working with a physician in the current statute for many, many, many years, and when that physician decides to retire, the midwife can't practice.
So let me just follow up on the comment you made that the nurse midwives want to work with hospitals to see these patients. Yes. And again, let me commend the Assembly member because I think you've done an excellent job in your presentation, and obviously you're very, very passionate. And let me also state that, for going on since 2006, I've done a great body of work on access distribution, communities of color, and rural communities. So I believe there is a great need. So don't get me wrong, I'm there just from the policy perspective. And yes, a nurse midwife does do good work, and I would very much support this bill if the corporate ban was not in it. However, let me just kind of stress some of the concerns that I have with the way it's currently written, unless you're willing to take some of the chair's amendments. So the problem is that under standards of protocol, physicians don't want to associate with nurse midwives, and I get it because of the liability issue. It's mainly due to the liability issue. If there was an independence, then you can separate yourself and not have that liability issue, and therefore there would be more nurse midwives that would be able to do several things, either set up a corporation, if the corporate ban wasn't there, be hired directly, they can contract directly, et cetera. So because there's a lack of the ability for the physician to work with a nurse midwife, I really believe that the best thing that should be done is to allow nurse midwives to practice independently, but practice independently without any restrictions. And here's the concern I have, and I know that the numbers were stated at 14, that is a small number because that's the very few that have the ability to do some kind of standard of protocol with a hospital right now. But if that were eliminated, that number could go up dramatically. And that number potentially could be much, much higher, and you could actually attract more nurse midwives, perhaps from other states. It could be a boom to the state of California with regard to attracting nurse midwives. But more importantly, now you have the ability to create other types of business models by a hospital that can be entrepreneurial and take the onus as far as overhead sharing with regard to malpractice, keeping their overhead down. So I think it's a unique opportunity for nurse midwives to go in and to be able to not only go into the rural but the inner city with the hospitals, and even if it were the nonprofit hospitals, to get away, because I know CMA's opposition is that it's for profit, there's undue influence. But I wouldn't even mind going a step further and looking that any provider like a nurse midwife, that there be some kind of statute that says that any entity can't unduly influence the medical decision of that provider. So if that were the case, then I would be totally supportive. So the reason why I'm not supporting the bill is not because of the merits of what you're trying to achieve.
I understand.
I think it's righteous, but my concerns are the fact that you're going to be limiting some of these areas to actually increase the amount of nurse midwives in those particular communities. I don't need a response. This is just a comment.
He doesn't want a response.
Other questions are coming? Yes, Senator Wachowski.
I thought I heard you say at your introduction that you were not accepting the suggested amendments on parenthesis A, but that you were accepting the amendments B, C, and D with the exception of striking likely and adding with the potential and striking significant. Yes. Is that correct? Okay. Then if I go to suggested amendments A, when I read page 14 of the bill, it talks about at line 17, a clinic operated under section 1206, and then you get down to line 29 and 30, and it says a clinic alternative birth license under 1204, paragraph 4, subparagraph B. So when the first part of this suggested amendment on A talks about just any clinic operated in a subparagraph A of 1204, I assume that that's some other type of clinic that's not covered. That's what the amendments are going to include, all clinics. Am I correct, A, with the analysis, or my reading, and then B, what type of clinics are these?
So I want to.
And then why is it a bad amendment? That's the third.
Oh, So right now, and as I mentioned to the chair, that some of the amendments they actually asked for are already existing in the bill. The one that's missing, clinics, right now we said in our bill is nonprofit, and I think that your concern was that meant charitable clinics. Isn't that what you said earlier? I just want to make sure we're
Nonprofit
nonprofit, but those
clinics, but scientific and charitable purposes. So
yeah, research and charitable clinics are included in the bill as written.
No.
Right?
Yes.
Yeah, but I'm asking on sub,
What? I'm sorry.
I'm going to get to hospitals in a second.
I just
This
want
is
to make sure
clinics.
that we're correct. Okay.
We have a subparagraph A and subparagraph C, and a 1206 and a 1204. So this is 1204A, which has got to be some type of clinic.
1204A is
Research
primary.
Let me
Research
ask
clinics and
Sarah Huckle to give you the breakdown of the clinic
and
definitions
D is
as in the bill and as before. Sarah, if you would please. Huckle, thank you.
Clinic?
Senator, do you have a question about the amendment clinic or?
Correct.
Okay.
Yes.
The amendment clinic would exempt nonprofit clinics and hospitals. Subdivision 1204A references 501c3 nonprofits. The current exemption to CPM is very, very, very narrow. It's a different subdivision in the Health and Safety Code that refers to a very, very narrow number of clinics that do exclusively scientific and charitable purposes. It refers to clinics that have to publish a number of studies per year. It refers to clinics that have to do completely free work. It's probably less than 5.
And districts, right?
Yeah, healthcare districts.
And healthcare districts.
So this would, so the suggested amendment, which is not being accepted, would I don't want to say generic clinics, but what I think about when I say any 501c3 clinic, rural, urban, whatever. And the reason you're not accepting that amendment is because I understand the research clinics. I got that the first time. Why is that a bad idea? Forget the hospitals for a second, just the clinics.
Wait, well, first, just to be clear, certified nurse midwives with this bill can continue to work in nonprofit clinics. They would just have to continue to work there. They can be employed there, but they would have to be certified. So that's what the amendment supervised. Sorry, oh my gosh, supervised. So that's what the amendment refers to is the supervision or not lack thereof at that clinic. Now, why is it a bad idea? The truth of the matter is, in a perfect world, it would not be a horrible idea. But the realities are, and as I said in my opening statement, is the politics that have actually ended up surrounding this bill have actually taken over the original purpose of the bill. And so the politics of the bill in this building do not allow those two things, the two things to exist in this, at the same time. So I can't accept the amendment and move it here. I can move it, but I can't move it back on my floor. So the reality is the politics of this bill have taken over the realities of what is and isn't possible, unfortunately.
Because I want to be sure in my mind that I have a scientific-based clinic, a generic nonprofit clinic, a nonprofit hospital, and a for-profit hospital. I think that we're slicing things, right? I get it, and I can appreciate the politics of the whole thing.
And also,
too.
90% of hospitals are nonprofit hospitals, right? So they work under that auspices, 90% of hospitals. So when we talk about the concerns about for-profit and nonprofit hospitals, obviously that exists in both spaces.
Thank you, Senator. Would you like to close?
Mr. Chair and Senators, first I want to thank everyone for taking the time. I know this has been the actual bill apparently not as complicated as the actual ban on the practice of corporate medicine. At this time, though, Mr. Chair, based on the debate and the remaining questions about this corporate practice of medicine, perhaps we should make this a 2-year bill. I would say I commit to working with you in the committee, but right now, clearly there are other issues that need to be addressed, and we will continue to work on our side to do what we can to address both houses' issues with this bill so that we can find a way to do what's best for women in the state of California and worry much less about what's best for those people politically. But for now, I would ask very much, and hopefully we can reach an agreement in 2016, so I will ask that we make this a 2-year bill, sir.
Be happy to do that. Very good. Thank you. Thank you to all the witnesses. Thank you to the committee, the outstanding questions. We are adjourned.